what I really like about the next speaker is every symposium I've ever attended, there's always new strategies going on in kidney cancer, and every day things change. And getting updated on what is new, I think, is critically important. So we're fortunate to have Dr. Joe Clark speak. Dr. Clark is MD is the Dorothy W. and J.D. Stetson Coleman Endowed Professor in Oncology, the Chief of the Division of Hematology Oncology, and the Regional Director of Oncology Service Line at the Loyola University Stritch School of Medicine, Loyola University Medical Center, and Cardinal Bernardine Cancer Center in Maywood, Illinois. He chairs the Data Safety and Monitoring Committee for the Cardinal Bernardine Cancer Center, and previously served as the Program Director for the Hematology Oncology Fellowship Program for 10 years. His Hematology Oncology Fellowship training was at Fox Chase Cancer Center and Temple University, combined in Philadelphia, Pennsylvania. He has been a faculty member in the Division of Hematology Oncology at Loyola for 30 years. His clinical and research interests lie in the field of immunotherapy, specifically with regard to the treatment of kidney cancer. I would like to welcome Dr. Clark.
Thanks, Joel, and thanks to the Judy Nicholson Kidney Cancer Foundation for inviting me. This picture is about 10 years old, back when I had hair, so I apologize for that. But anyway, we're going to talk a little bit about kind of what clinical research is and kind of how to navigate the environment for you, right? For you as a patient, for you as a caregiver. What are the things that I can look for that are new or exciting, or something that I might want to pursue as a patient for treatment of my kidney cancer? So I do clinical research, so we always have to explain what our resources are and what we get. So these are my disclosures. Any of the clinical research I do, we get support from various entities, as you see here, for the institution. And I will be talking a little bit about non-FDA approved therapies, kind of what you heard in the previous talk, things that are being studied in kidney cancer. So just as a way of outline, I'm going to talk about a broad history of where we are today based on all the research that was done in the past, right? How we got to where we are today. I will talk about what types of research are being performed in kidney cancer. I'll talk about, in general, studies, and then specifically with kidney cancer. What is a clinical trial and why participate in a clinical trial? The types of the, I can't read my own writing, sponsors, all right, so types and sponsors of clinical trials. Where to search for these trials, and then lastly, examples of ongoing clinical trials and what's being studied locally, regionally, nationally, actually even internationally. So as you can imagine, lots of people studying how to treat kidney cancer better than we already are today. So what are types of treatment available? So you saw earlier, obviously, we have surgery. That is really the primary treatment when we think about treating kidney cancer when it's first diagnosed. That's always the first thing we think about. And you heard from our surgical colleagues methods of resecting the primary cancer. And not uncommonly, we will resect or remove metastatic lesions, right, if they're resectable and there's not too many of them. So that's always something we think about, for sure, in the beginning of the therapy, and then not uncommonly later on if the cancer tends to progress. You heard about other local therapy, radiation. SBRT is just an acronym for stereotactic body radiotherapy. So you may have an isolated metastasis that has spread, say, to the lung. The radiation oncologist can target very high energy radiation to that particular site. They might think about that for the primary tumor. They might think about that for a distant site. Generally speaking, radiation has a bit of a limited role. It's more so for people who may not be a surgical candidate, who might have an isolated metastasis, that sort of thing. And then you heard about RFA, radiofrequency ablation. There's cryotherapy. I didn't go into a lot of that, but those are other localized treatments for kidney tumors. Then you have cryotherapy that I just mentioned, and then there's systemic therapy. So a lot of people in the room, I'm sure, either are on systemic therapy, have been on systemic therapy, know someone who's been on systemic therapy. So as a medical oncologist, so I've been at Loyola my entire career, mainly because I couldn't get a job anywhere else, but don't tell anybody that. Love that place, and I've been treating kidney cancer patients my entire career. What I do is systemic therapy, right? So when you hear that term, that is, doctors like to talk in like Latin words and really words that people don't understand so that we can just make them seem like we're smart. But systemic therapy just means it goes all over the body, right? So drugs. What types of drugs do we use in cancer? Well, really, if you think about the past, we used a lot of cytotoxic chemotherapy. Those drugs really don't work in kidney cancer, right? So we have other forms of therapy. I'm sure a lot of you have heard of immunotherapy, right? Now we used to use a lot of cytokines, interferon alpha, interleukin 2, high-dose interleukin 2 is something I made my career on, treating patients with that agent. We really don't use that drug much anymore, but that's based on all the research that's been done in the last 20 to 30 years. We have better, newer treatments now, right? So immunotherapy, checkpoint inhibitors. There's other forms of immune therapy that are being studied. Cellular therapy, tumor-infiltrating lymphocytes have been looked at, dendritic cell vaccines, natural killer cells, things like that. Those are drugs designed to manipulate the immune system, to recruit immune cells into the tumor to kill it, allow the immune system to do the job it's supposed to do. That's really how checkpoint inhibitors work. There are what we call targeted agents, targeted therapies. I'm sure most of you are familiar with those. The vast majority of those are oral. Those are drugs you take by mouth. A whole lot of those types of drugs. I don't show this, but you could look on the NCCN guidelines and you will see 15 different targeted agents that are out there, or combinations thereof. And then, as I mentioned, combination therapy. So immune therapy combinations, targeted therapy combinations, combinations of immune and targeted therapy, all kinds of iterations. And how did we get to today? Based on clinical research, right? Research, I'm sure a lot of you have been on studies, clinical trials. I will talk about shortly why enroll on studies. But so a brief history, I just talked about that. Besides surgery, which has really been an established treatment for kidney cancer since time began, it's really the last 40 to 50 years the field has just advanced, and it is going to continue to advance, by the way. And a lot of it has to do with people like you in the room who are participating in clinical trials. You're doing it to help yourself, but the reality is you're also helping future generations, right? You may or may not realize that. But as a clinical researcher, right, as a physician who treats people with cancer, especially at an academic institution, one of my passions, one of my goals is to make treatments better for future generations, right? Where we are today is much better than where we were 20 years ago, but we have so much further to go, right? So enrolling patients on clinical trials, patients volunteering to be on clinical trials is really important. So again, I just summarized chemotherapy doesn't really work in kidney cancer, but was tested for years. Cytokines, interferon, high-dose interleukin 2, and now today, checkpoint inhibitors, targeted therapy, combination therapy, you name it. So I'm just going to really talk in general about what is research, right? So how do we think about research? What types of research do we do? And then focus a little bit more on the kidney cancer side. But when you think about research, a lot of people think about the lab, right? The scientist who's got a lab and they have microscopes and they're doing all kinds of things in the lab. And that's really where research starts, right? People have ideas and they say, let's think about this. Let's study a particular disease, a particular gene in a particular tumor, whatever it might be, and study it in the lab. And if there's promise in the lab, it will then move on to animal studies, right? So you think about mice and dogs and rats and whatever. So it showed promise in a petri dish or what have you. Let's try it in an animal to see, does it work? Does it actually kill cancer cells in a rat or whatever? Is it safe? Are we treating these animals and are they all dying? Well, maybe that's not the best treatment we should be offering our patients. But if it shows promise in animal studies, then it moves on to clinical trials, right, for patients, for humans. And so that's where clinical research takes its, kind of runs with it, right? So a clinical trial, really, if you think about it, is simply an effort to find either a new treatment or a combination of a treatment to further advance the field in the particular disease you're treating, in this case, kidney cancer, right? So we already know where we are today, but we want to get further ahead. Clinical trials are just an effort to do that. And you have to, people think it's, you probably heard the same term, but am I a guinea pig, right? Am I going to be a guinea pig? Why? I don't want to be a statistic. You are not a guinea pig, right? You are going to see a physician who is really interested in trying to advance the field. They're going to do everything they can to help you. If they have a trial they're presenting to you, it's because you are an appropriate candidate for that study. It's designed for you. It is designed for someone in your exact situation. It's not, we're just going to throw something at anybody and see what happens, see what sticks. So that's really what a clinical trial is. And so what are the types of clinical trials? So you may or may not be familiar with these terms. We have what we call phase 1, phase 2, phase 3. Phase 1 is the first set, right? So it comes from the lab. It's been studied in the lab. It's been studied in animals. And now we want to further it into the humans. So we do what we call phase 1 trials. And a lot of people have a misconception of what a phase 1 trial is. To be perfectly honest, a phase 1 trial is simply trying to identify an agent or a combination of agents that are safe, right? Is it safe to administer in human beings? So they'll usually start off at a low dose, a schedule that looks safe in an animal, and we're going to start it off in a human, and then they'll push it until they find the safest dose and schedule for whatever agent or combination people are looking at. So it's not necessarily even though our hope is we show activity, right, anti-cancer activity, the reality is it's really a safety study, right? Is it safe? But ultimately, the goal is to identify diseases that it's going to work in, right? So a lot of phase 1s, anyone can enroll, but if there's certain disease entities that do better, then we're going to move it on to phase 2, right? So now you move on to the phase 2 trial, which is an efficacy trial. So efficacy means, does it work? Does it control the disease? Does it control the cancer? Does it make the cancer get smaller? Does it make the cancer go away? Right? So that's a phase 2 trial. And so as a clinician, as an educator, we use the term efficacy. Does it work? And generally speaking, those studies will have statistics. So they will be a predefined, we want to, if 40% of people do well on the study, then that's good. We will then move it on to the next level, phase 3. Whatever that number might be, you sit down with a statistician, you decide what makes sense, what's appropriate. So that's a phase 2 trial, so you may have heard that term. But that's where everyone has the same disease, treated with the same drug, same agent, right? It's not a phase 1 where anyone can enroll. We've identified advanced kidney cancer patients, whether it's clear cell, papillary, whatever. We're using this particular agent, this particular dose, this particular schedule. Everyone's getting treated the same way. That's a phase 2 trial. Now, phase 3 is kind of the one that most, I think in the public, people hear about more than anything else, right? When on the news or a press release or what have you, where, say, either a company or a national group has studied This particular treatment that we just showed in a phase 2 trial is active. It shows this degree of benefit for this many patients with this disease. Now we want to test it against what's the standard, right? What is the current standard treatment for people with stage 4 clear cell renal cell carcinoma? I have this new agent. I want to see, is it as good as the current or better, right? And that's really how you advance the field, right? So that's why we are today with all the drugs we have. These agents were studied in the phase 3 setting. You will hear a lot about pharmaceutical companies. Some of them are here today. They do a lot of phase 3 trials, right? That's how they get their drugs approved and on the market. The cooperative groups, which I'll mention shortly, we're also trying to advance it. We don't have those new drugs, right? Companies and others have them, but we're trying to further it even beyond getting it on the market, right? Are there more patients who might benefit? Different diseases with these particular agents. So anyway, that's where phase 3 comes in, and that's kind of what I think most people are familiar with. And then I talked about why participate in a clinical trial, and everyone has their own reasons, their own rationale. A lot of it you heard earlier is hope, right? I'm hopeful I have a new option, a new treatment I can pursue. I've run out of options, right? I have gone through the whole 15 drugs that are out there, or combinations, and I still have my health, and I still want to pursue something. I want to find a clinical trial that I can roll in. And to be honest, a lot of it is altruism, right? I want to help not only myself, but future generations, right? So, and you have to understand that. That's what clinical trials are, right? It's to help you, but also to help people in the future. So, who sponsors clinical trials? There are really 3 main sponsors, if you think about it. One, investigators, right? So someone like myself, the rest of the investigators here in the room might have an idea. I want to test high-dose interleukin-2 in advanced, stage 4 kidney cancer. That was a concept 30, 40 years ago. It eventually became approved and became a standard treatment because it was studied and shown to be effective. Checkpoint inhibitors today based on that. So that was initial concept from an individual, investigator initiated. It's usually limited to one institution, maybe a handful of institutions who are cooperating. So really a smaller study, but kind of a first thought, first novel concept. Then you have the cooperative groups. So these are national groups of institutions around the country. I guarantee you, each academic institution around the country belongs to one or more cooperative groups. And so they meet on a regular basis. They talk about the studies that are ongoing and what future studies might be. And these are just really the main ones, the main players in our country right now. So SWOG, Southwest Oncology Group, ECOG, Akron, Alliance, NRG. These are just acronyms for these cooperative groups. You may or may not hear of them, but they are looking at the bigger picture. They want to enroll lots of patients on big studies to try to further the field. And then, of course, pharmaceutical sponsors. A lot of studies internationally sponsored by cooperative or pharmaceutical companies. They have the resources to do these really large national, international trials, right? And their goal is to get drugs on the market, right? Their drug on the market. But really, they're not going to do that unless they show these drugs work, right? These agents are effective in controlling a cancer, curing the cancer, whatever it might be. So you'll hear a lot about pharmaceutical trials, and that's what press releases are, right? They're showing everyone, look, this is what we did, and we're going to get it approved. So those are really kind of 3 basic sponsors of clinical trials. And really any institution, so if you go to an academic institution in the city or really anywhere, they will, for the most part, have access to one or more of these types of trials. They may have all these options, they may only have 1 or 2, but they, generally speaking, have access to these types of trials. How do I search for studies? Where can I look to figure out what might be something I can look at. And I'm sure most of you have kind of searched this, clinicaltrials.gov, right? That is the National Cancer Institute's, NIH really, website that has every single clinical trial that is registered in their data bank. And if you go on clinicaltrials.gov and type in kidney cancer, there's page after page after page, and it gets confusing, right? Oh my God, I can't. And you can filter, you can say papillary, you could say, chromophobe, you could say open to accrual, right? Because that's really the ones you're most interested in. But if you don't filter it, you're going to get studies that have been closed for years. They're still labeled on there. But that's really kind of the main one, and that's where a lot of physicians look too, by the way. So clinicaltrials.gov is a good resource. Any of the academic institutions in the city will have websites that you can peruse. They may or may not have all their studies listed. They will definitely have a link to how to connect with their cancer centers, right? So they may or may not have the studies listed, but they'll tell you this is the number to call if you are interested in clinical research or clinical trials, how to get a hold of them and talk about, do they have studies open for you? And you can really just communicate with them first before you make an appointment. Do you have studies open for, stage 3 papillary renal cell carcinoma or not, et cetera? So those institutions, and then obviously your kidney cancer foundations are always good resources. They may not have all the studies listed, but they'll help guide you to who to talk to, who to go see, who to Google, what have you. They know a lot of the people around the country or in the city and around the country, and they'll guide you. So really, next, I'm just going to really give some examples of current studies that are ongoing in the region, and then really examples of what's being done nationally and even internationally. So it's not anything for anyone to kind of memorize, but it's just to show you there will always be clinical trials. I guarantee it. Throughout time, there will always be options available to patients. And studies open and close all the time. So you may hear about something, go talk to an investigator, and they say, well, you know what, I'm sorry, but it just closed, a week ago. Because, again, statistics, right? There has to be a certain number of patients enrolled, and then they look at the statistics and decide, can we move forward? It just can't be an open-ended thing. It's not feasible to do that because these things do cost money to run these trials. But anyway, these are examples. So this trial, this PROBE trial, is an ongoing trial. It's a cooperative group study, but it's for people with localized kidney cancer, and they are randomized between systemic therapy with checkpoint inhibitors or surgery. And they have to decide, it's a randomized trial, so they don't get to decide which option they do. If they do well with the checkpoint inhibitors, they may never need surgery, right, versus operating up front. So it's a novel concept, right, treating localized disease with a systemic therapy. But that's for people with kind of early stage disease. This RADICAL trial is a study that's now closed, but it was really looking at a novel radio conjugate for patients with papillary renal cell metastatic to the advanced renal cell carcinoma metastatic to the bones in combination with cabozantinib. So it was a novel way of thinking about treating people with metastatic disease to the bone. And then this PAMPET trial is a study strictly for papillary renal cell carcinoma patients using a novel drug in combination with a standard drug, so cabozantinib, for people with papillary renal cell. But it's for upfront metastatic disease, so they haven't really undergone prior treatment. So they can enroll in the trial. And I didn't mention that. So randomization, right? So what does that mean? These are what phase 3 trials are. Sometimes phase 2 trials are randomized, where patients have a disease, they want to enroll in a trial, and there are 2 different arms. There may be 3 arms. But you don't get to pick which treatment you get, right? So you're randomized, and it's usually a 50-50 chance between treatment A or treatment B. and treatment A be the standard, and then treatment B is the new one, or a combination of the new one plus the standard, you don't get to pick which of those you get. The physician you're seeing doesn't get to pick. Your friend down the street doesn't get to pick. Your brother doesn't get to pick. A computer decides, right? And you have to be willing to let that happen, right? You have to be willing to say, yes, I am willing to let a computer pick A or B. And generally, I guarantee you, if you're in a randomized trial, the very least you're getting what's the standard treatment, right? So that is what you would get anyway if you weren't on the trial. So just remember that. A lot of people, that's where this guinea pig thing comes in. People don't, like, what do you mean a computer is going to decide? It's okay. You're going to get at least the standard. Sometimes the standard is nothing. So that's where a placebo comes in. And then they're trying to see, is this new treatment better than not doing anything, right? And sometimes it isn't, by the way. So just remember that. That's what a randomized trial is. You know, it's a flip of the coin, and that's okay. It's either the standard plus something else or the standard. So that's what this Pampa trial is. And then there's this trial, PEAK 1, is a randomized double blind, which means neither the investigator nor anybody else knows what you're getting. Okay, that's what double blind means. Only the computer knows what you got. And so this is a study that hasn't yet opened, but it's going to be a phase 3 international trial, pharmaceutical sponsored study using a newer drug in combination with cabozantinib versus placebo plus cabozantinib for patients with advanced clear cell kidney cancer. The rest of the slides are really just what's out there today all over the country. If you're willing to travel, right, you can look on clinicaltrials.gov. So there's University of Pittsburgh. There is South Korea, right? So you could travel outside of the country. You can go to Sweden. You can go to Canada. If you go to Canada, you may want to just stay in Canada these days. But anyway, there are university in Houston, MD Anderson, right? A number of people have probably been there. There's New York. There's Chicago. There's really any place around the country. So the specifics aren't really that important. You can look this stuff up on the computer. The point is there are active investigations, clinical trials being done all over the place, anywhere you might want to go. So in conclusion, I really just have a couple of summary statements. I wanted to keep this broad to give you a better understanding of what clinical research is and what we do. But the treatment of kidney cancer has evolved dramatically in the last, even in my career. For years, I treated everybody with high-dose IL-2 if I could, or I put them on a trial. Now we have so many different newer agents, combinations that are approved that you don't have to be in the hospital for. So many more treatment options are available today, as I mentioned, and many more will be available because of studies that are being done today and in the future. And so we, as investigators, as physicians who treat people with kidney cancer, appreciate people's willingness to enroll on studies. We wouldn't be where we are today without that. And your generations beyond you are going to benefit from what you're doing today. So thanks. I'm happy to take some questions.
When studies are done in different countries, how is that information shared with the medical community?
That's an excellent question. So the question was, when studies are done internationally, how is that shared with the medical community? And there's a number of different ways, but the biggest one is with our national meetings, right? So what we call ASCO, American Society of Clinical Oncology, is in Chicago every year. And that's where all the big studies, really any study that has information to share is presented. And all the investigators are there. They're going to hear it. It gets on the news, things like that. But then there are smaller studies that are done, or smaller meetings that are specific, right? Kidney cancer or GU oncology meetings, where they happen more frequently throughout the year, and that's where information is shared as well. So it's a network around the world. Most of these individuals know each other, to be honest with you. Joel.
You make an excellent point about the placebo because there's still a lot of people out there that believe that when they're on a clinical trial, they're either getting the treatment or nothing, and that nothing isn't the standard of care. So I think it's really important to understand that when we get the placebo, that's because that would have been the standard of care. We were always getting treated. And I think that's really important, and that's a myth we got to debunk. Anything on CAR T cell for hard tumors? And one of the drugs that we see in my Facebook community is a lot of success with Cystatofan.
So it's an excellent question with regard to clinical trials and then CAR T, et cetera. So investigational now. The CAR T, you may or may not be familiar. That's chimeric antigen receptor T cell, and it's now approved for other hematologic malignancies, ALL, even Hodgkin's lymphoma, et cetera. But that is being moved into the solid tumor field. So purely investigational now. Certainly worth pursuing if someone has kind of run through a lot of the options that are available. It hasn't yet been proven. We have certainly done similar types of trials using different approaches. TIL cell, I mentioned, dendritic cell vaccines. Similar concept, but really you're trying to manipulate the immune system. So there's hope. Have we figured that out yet? Not yet. But there was hope with checkpoint inhibitors. We didn't figure that out until later on. And look at where we are today, right? We have checkpoint inhibitors that are pervasive in everything, especially kidney cancer.
Cystatofan, have you been reading up on that one?
I don't know a lot about that one, so I can't really say much.
Yeah, hi. Checkpoint inhibitor, what is that? I mean, is that different than immunotherapy or TKI? Could you?
So checkpoint inhibitors are a form of immune or immunotherapy. A few of the drugs that are out there now, right, Yervoy and Opdivo and Keytruda, these are drugs that allow the immune system to effectively do what it's supposed to do, which is recognize cancer cells and kill them. That's really all they do. They don't kill anything. They just let your immune system do what it's supposed to do. Because clearly, when you have cancer, it's not doing what it's supposed to do. And so this is a way to educate the immune system to say, get out there and kill.
Back to the CAR T question. Is that only used for, I heard you say, like just one solid tumor mass? Or if you have metastasis and numerous things going on, would that type of therapy not work if somebody has multiple areas? And
So the concept CAR T cell therapy is really for disseminated disease, which is what you're asking, metastatic. For localized disease, that's where surgery, radiation, radiofrequency ablation, that sort of thing comes in. CAR T is a way of manipulating the immune system to attack the cancer wherever it is.
And is that only for one type of cell, like clear cell, or is that?
So the question is it only for like clear cell versus papillary, et cetera. So those are clinical investigations, clinical trials. There isn't any proof yet that that's going to be effective in any type of kidney cancer. It's being studied. So our hope is eventually, yes. So eventually it'll be studied strictly in clear cell versus papillary, what have you.
Are clinical trials really only recommended like for patients where other treatment options have failed? Or like what's your take on it?
The question was, are clinical trials only for people who've been through multiple therapies and there's nothing really out there? Clinical trials can be done anytime. I showed you a couple of examples for early stage disease. Should we do, like, if you think about nephrectomy versus partial nephrectomy, right? That could have been a clinical trial where half the patients had a partial, other half had a nephrectomy. So there are always studies being looked at early in the disease setting, after one or two prior treatments, multiple prior treatments. So don't feel like I can only do that if I've had 27 different treatments.
Do you know, is there ever any evidence that immunotherapy is effective against papillary?
That's a really good question, and there is data to support checkpoint inhibitors and or in combination with targeted drugs. Those are those oral drugs that I mentioned. So yes, there is some data to support that. you heard earlier, the results aren't quite as good as they are with ClearCell, and I think you're going to hear a little bit more about that later with one of my colleagues here, Dr. Stadler. Okay, thank you.
Thank you.